That's done. So we'll be starting in just 5 rows. If you want to have a break or take a cup of tea or something.
I'm all good. Yeah, I was working at the Children's Hospital today, so at the retrieval team. So I said to my boss at 5 o'clock, I need to go. I need to go and battle the Melbourne peak hour traffic, and make sure that I'm back well in time for Alok's talk and be not frazzled. And yeah, so yeah, that was good.
What's COVID like in Melbourne at the moment?
A non-event. So we have no cases. We've had no cases now for 39 days. We had been having a rollout of both the AstraZeneca and the Pfizer vaccine. So healthcare professionals were getting the Pfizer, and then the general public were getting AstraZeneca. But then they ran out of Pfizer, so they started giving healthcare professionals AstraZeneca. Then, of course, these rare blood clots. So the TGA here in Australia, the Prime Minister got on last night, and they've just declared that nobody under 50 is to have the AstraZeneca.
Yeah.
So that's just put a bit of it'll slow down the vaccination, but we're in a very unique position in that we don't have active COVID in this country, other than in a hotel quarantine. That's like 3 or 4 cases. So there's not that sense of urgency, I guess, to have people vaccinated. And of course, they're happy to give the AstraZeneca to over 50-year-olds, who are obviously our most vulnerable population. So we're really, we've still got, borders open and closed, even though we're one country. So at the moment, there's parts of New South Wales that are still what's called an orange zone, meaning they've had one case. So for me to come, if I went into New South Wales, I'd have to get a permit to come back into Victoria because they have one case.
Wow. And do you have to quarantine?
Not quarantine, but I would have to be COVID tested and then isolate until I got my result. And for me to enter the Royal Children's Hospital, I would not be able to enter the hospital for 14 days.
Ooh,
yeah. So therefore, I was supposed to be going to Byron Bay this week, but I'm not. Yeah, so it's been obviously a very different experience to what's been happening in Europe, and I think we've been so lucky being an island nation that we literally could close the borders. But I think what nobody in Australia was expecting was that within states, that states would close borders. It was so there was a period of time where I couldn't get home to see my family for 10 months. During lockdown, similar to what everyone's been through, but that was strange given that they're in the same country as me.
I mean, very similar in that, well, we haven't had a significant lockdown between parts of the UK, but there was a similar kind of a curtailment for us moving to Wales and us going to Scotland. In fact, Scotland had closed its borders for a bit in order to try and minimize movement. Obviously, the vaccination program here has done leaps and bounds. So we're keeping our fingers crossed that we'll be able to come out of lockdown come the 12th. So from the 12th, apparently, we'll be able to eat outdoors. Families can meet in the back garden already. But
it was just after, excuse me, we were in lockdown for Melbourne for 110 days. 110 days. And during that time, we were only allowed to go 5Ks from home, other than for work or healthcare. You couldn't have anyone over to your house who didn't live in your house. And then and around day 90, they created these bubbles where you could have a bubble with one person from one other household. So when the restaurants first opened, it was very strange because everyone was quite nervous because we'd been in that, lockdown for so long, to then be suddenly told, I can go and eat out. And of course it was summer, which was better. And Melbourne, obviously, all the outdoor cafes, so that worked really well. But it was a very strange feeling. It felt like you were breaking the law. And I have to say, I've only just started going back to eating inside in restaurants, and that's taken me a long time. to feel comfortable to do that. Yeah, it's
Completely
been,
agree. I mean, it'll be unique for us as well. I mean, I think
mm,
I last ate out in a restaurant.
mm,
I can't even remember, but I think it was
yeah,
when we had a temporary opening of lockdown in
yeah,
September last year. So it's
yeah.
yeah, it'll be
And the
interesting.
first time I gave one of my close friends a hug instead of just, the elbow, um, yeah, that was the strangest day. So, how much has it changed our lives in a year? Just extraordinary, really. But as we all know, babies keep being born, and so we just life went on in terms of the hospitals and babies and retrieval, and yeah, just COVID safe.
What I'm going to do, Rose, is I'm going to make a start just by giving participants an introduction.
Mm,
We've tested the line, so I can confirm the YouTube link is also working for the participants from the hospital and the network. So I'd like to welcome everybody today to one of our sessions as part of our perinatal ethics module. And we have Dr. Rosemary Boland, who is a postdoctoral researcher working in Victoria, who's going to speak to us today around the guidelines on limits of viability, give us a little bit of a flavor of how they've developed these guidelines, but more importantly, I think from our perspective, give us a completely different perspective to the one that we currently have in the UK. So just to give everybody an idea, we're expecting the talk to be about 45 minutes with questions at the end. So you'll all be muted on entry, and I would strongly advise that you not unmute yourself to avoid any disturbance during the talk. At the end of the talk, I will invite questions. In the interim, if you have any questions, I'd strongly recommend that you put them through the chat function so that we can direct them through a moderator, and that'll be me, just to avoid us speaking over each other. Feel free at the end, obviously, we will invite a little bit of a live interaction with Rose, especially for the participants who are live at the moment. But for the participants who are watching by YouTube, you can ping me on WhatsApp if you have any questions, which I can then put to Rose. Without further delay, I'm going to hand the floor to Rose. And thank you so much, Rose, for giving us this opportunity to interact with you.
Not at all. Thank you, Alec, for the very kind invitation. I was very honoured to be asked, and I hope that this talk will be of interest to you. When I first sat down to write it, I sort of thought, well, do I just talk about the guidelines, or do I talk about the development, or do I sort of try and tell you a little story? And I decided that I would weave this into a bit of a story. So I am actually a neonatal nurse by profession. I trained originally in Sydney, and then after I finished my midwifery, I actually came and worked in London for a couple of years, and I worked down at St George's Hospital in Tooting. And it was there that I started working in the neonatal intensive care unit, and I nearly stayed and did the EMB 405 course. This is 1991. But in the end, I actually came back to Australia to do my Master of Nursing. And here I am, 30 years, literally 30 years this year. I now live in Melbourne, where I've been for the past 23 years. I work predominantly on our baby's newborn emergency transport service, which is called PIPER. And that is a very long-winded way of saying the Paediatric Infant Perinatal Emergency Retrieval Service. But it was from that work really where my PhD work was driven, because over those years of working in retrieval, neonatal retrieval, I became really interested in outcomes of babies born in non-tertiary hospitals, and why it is that, or was that, despite our best care, our best transport card, a dedicated team, that often these babies had such poorer outcomes. And so,
Rose, sorry to interrupt. We just need, are you sharing your presentation?
I will do shortly. Yep.
Oh, my apologies.
I shall do. Yep. Just giving you a bit of a blurb. But yeah, so that was kind of the background. Actually, I'll start sharing now, Alex, so you don't get anxious that I'm not going to show you something exciting. So there it is. Yeah. And so for my postdoctoral work has really been around trying to improve outcomes for extremely preterm babies, particularly those born in non-tertiary hospitals. And this was how it came to be that I took on this role of helping to develop these statewide guidelines for Victoria. And I always find it interesting when we use the words limits of viability, because in many ways, and I often think about this word, what do we really mean by the limits of viability? Well, if you look it up in the dictionary, the Latin vita tells you it means alive. But there's various definitions, but really the capability of the fetus to survive outside the uterus. And when I think about my career as a neonatal nurse, I can remember a time where if you were under 28 weeks, you weren't considered to be viable, as in, you wouldn't receive resuscitation. I was thinking how much things have really changed over that time. So what's happening around the world? Well, we know at the moment there is actually a really wide variation in the way management of these extremely preterm babies born at the really lower limits of viability, if you like, or the most immature babies at 22 to 24 weeks, how they're managed both here in Australia, both within different states of Australia, and certainly internationally. And there was a systematic review published by Goulian in 2015, which they identified 34 guidelines from 24 countries from 4 interprofessional bodies, all trying to develop guidance around how to manage these extremely preterm babies. And what we know, of course, is that there is an increased willingness to offer active care to these tiny babies in many countries, but certainly not all. And this was some work I published a couple of years ago now, which was just looking at the variations in rate of active management from a couple of cohorts here in Victoria, so in the white and the blue, in France in 2011. In the UK, now this was back in 2006, and in Sweden at a similar time frame. And what you can see back then was at 22 weeks that the Swedish were quite proactive. In the UK, just over 10% of babies were being actively managed, or 13%. Very, very tiny proportion in France, and Victoria was around 5%. Again, at 23 weeks, we saw this huge variation in this, in the way countries approached it. So again, the UK and Sweden up here, France down here in green, and here's the 2 cohorts from Victoria. And it really wasn't until 25 weeks gestation that we started seeing fairly universal approach to active management. But we know, of course, that management of these pregnancies and these babies involves some really important clinical decisions and important ethical decisions, which I'll get to shortly. But in terms of clinical decisions, do you give the woman antenatal corticosteroids? And at what gestational age do you start? Do you start at 21 plus 5? How early do you administer a magnesium sulfate for fetal neuroprotection? How early do you transfer the woman to a tertiary perinatal centre? Do you wait till she's 24 weeks, or do you transfer when she's 21 or 22? How are you going to birth that baby? Because obviously, if you do a caesarean section at 22 weeks, then it's going to have to be a classical, and that'll obviously have implications for that woman's future pregnancies in terms of risk of uterine rupture. Do you resuscitate the baby at birth? And how aggressive are you with that resuscitation? And then do you offer that baby neonatal intensive care? And that might mean transferring them from a non-tertiary hospital to a tertiary perinatal centre. And of course, that decision to provide active management or passive care or palliative care or comfort care, as the many names we use for it, really determines the baby's outcome, because it is a self-fulfilling prophecy. If you do not provide active care, then the baby will die. So I then, or before we started the guideline, I started looking at then what was happening around the world right now. And this is the most, some data from Sweden. And these couple of slides, I'm only looking at all studies that use all live births as the denominator, not studies that only report NICU admissions. So we can see in Sweden that at 22 weeks, it had 96 live births, and 52% of those babies were offered intensive care, with a 1-year survival rate of nearly 60%, so fairly impressive. At 23 weeks, you can see in Sweden, close to 93% of live births were offered intensive care, with 66% survival. And at 24 weeks, it was close to 100% in Sweden, again with very high survival rates. What about in the UK? Well, this is the latest data from the Embrace report. So these were babies born across the UK in 2016. And we saw at 22 weeks, there was 183 live births, only 15% offered intensive care. But the babies who were offered intensive care did quite well, with more than half of the babies surviving. And again, you can see the data for 23 weeks and for 24 weeks. What about in Norway? So in Norway, I'd say only 17 live births, but nearly a third were offered intensive care and about 60% alive at 1 year. So again, look at the denominators, 60%, you think, wow, that's a high survival rate. But they only offered intensive care to 5 babies and they had 3 survivors. So again, the importance of looking at your denominators. And in Western Australia, which has really to date only been the only state in Australia who has been proactive with managing these very immature babies. This is the 2004 to 2010 data from WA. You can see 60 babies live born, only 5 offered intensive care, and 3 of those babies survived, again, giving them a, in inverted commas, 60% survival rate. So again, we can see wide variation around the world at the moment. This was France. Again, no babies at 22 weeks offered intensive care, and the Netherlands, intensive care not offered prior to 24 weeks. So it's not universal that all babies born alive at 22 weeks or even 23 weeks are actually offered intensive care. I'm just going to skip over, I'll show you this, but this is, actually we'll talk about it, but then you've got to look at, well, what about if they do survive to NICU? And I think what was surprising when I looked at this was perhaps people perceived that these very immature babies had very poor survival rates. And if they did survive, they would have very profound disabilities. We'll talk about that later. But in fact, the most recent data are a little bit more reassuring than perhaps many people think. So what's been happening here in Victoria? So just to orientate you, for those who have not been to Victoria, we are geographically the smallest state of mainland Australia, but we have the second highest proportion of births in the country. So the highest proportion of births are in New South Wales, followed by Victoria. And Western Australia, which is the biggest state, has the lowest proportion of births. So here in Victoria, we have about 80,000 births a year. Same statistics as anywhere, 8.3% of preterm. So it's around 6,500 preterm births a year. And although we may look small, if I put Victoria or put Australia on top of the map of Europe, here's Victoria covering this geographical area down here. And here is the whole of the UK. So in fact, Victoria is only slightly smaller than the whole UK put together. So just to put that into a little bit of perspective about the land size that we're dealing with. And so how was it that we came to develop this clinical guidance for these births at 22 to 24 weeks gestation? Well, the first thing that happened in Victoria back in 2017 was an organisation called Safer Care Victoria was established. And this was in response to the recommendations from a report called Targeting Zero. And Targeting Zero was a report that really looked at ways we could support hospital systems in Victoria to eliminate avoidable harm and really strengthen quality of care. And so Safer Care works with healthcare services and clinicians and consumers to run improvement projects, to develop evidence-based guidelines, to review adverse events, and to monitor sentinel events. So that was 2017 that was established. And then in 2018, there was a parliamentary inquiry into perinatal services in Victoria. And one of the key findings of the inquiry was that they recognised there was real disparity in outcomes between babies and women who lived in regional areas versus in the metropolitan area. There were challenges retaining workforce out in the regional areas in Victoria. And among the many recommendations that came out of this report was that the Victorian government, committed to developing shared policies and protocols in obstetric and neonatal care for health services across Victoria. So instead of each hospital having its own policies and procedures, that the recommendation was that there would be statewide policies developed to improve care. And another recommendation, 3.4, was the government would engage with Victorian hospitals to develop a training package on bereavement care for healthcare practitioners. The following year, a group called the Neonatal Advisory Committee, and this is a group made up of tertiary neonatal consultant neonatologists, the nurse unit managers, and other senior level neonatal staff. And again, what they recognised was around Victoria, we really had differing practices in the way that these births were being managed. And what NAG identified was really that we needed consensus from our tertiary centres and from Piper, our neonatal retrieval team, about the guidance that we were giving to non-tertiary clinicians. Because what we were seeing happen was, depending on what consultant might have been on for Piper that night, that different advice was being given to hospitals, different recommendations were being given to different hospitals, and that there was really inconsistent approach to the way we accepted in utero transfers into tertiary centres. We also, NAG came to the conclusion that we really needed a consensus on the definition of the zone of parental discretion. I'll really focus on this tonight. But also that Victorian women had the right for equitable access to high-risk counselling, irrespective of what hospital they were booked at or where they lived in Victoria, to help them make informed decisions about their baby's care. And with all this happening at the time, Safer Care then funded this project to develop the Extreme Prematurity Guideline. They appointed a project officer, which was myself, and then I brought together an expert working group, very similar to how the Banff guidelines were developed in the UK. And the working group consisted of obstetricians, neonatologists, both tertiary and non-tertiary, regional paediatricians, GP obstetricians, so these are general practitioners who do obstetrics, and these are often the sole practitioners, as in there's not a paediatrician in many of our smaller hospitals. We had a neonatal nurse and a midwife, and we also had a consumer who was a mum of a baby who was born at 23 weeks. And so we were tasked with developing this guideline. And so when we sat down and looked at, well, what did we need? We realised that, first of all, we needed a consensus statement defining the zone of parental discretion. And this, I think, was in many ways the hardest part of the guideline. And this took a lot of work, and I'll tell you a bit more about this shortly. Obviously, we wanted to develop guidelines for management of the woman who was at high risk of birthing at 22 to 24 weeks. And what we had to take into consideration for that was that one size was not going to fit all, that the guidelines for management in a tertiary perinatal centre would be different to a woman who presented to a small regional level 1 hospital. And for the same reason, we also have to have guidelines for management of the baby immediately after birth for both tertiary and non-tertiary hospitals. But that we also needed to develop guidance around palliative care and how that would happen and where that would happen versus active management of the baby. And then the fourth component was to develop parent information sheets for parents of babies who were born at 22, 23 or 24 weeks gestation, to give them some tangible written information on what it meant to have a baby born that early and what were some of their options in terms of active or palliative care, and what some likely outcomes might be for the baby if the baby was offered intensive care. So the first thing we had to do was actually define what we actually meant by active management versus palliative care. And when we thought about this in terms of active management, it was very important that it was clear that this was something that started well before the baby's birth. So you didn't just wait for the baby to be born and then decide, now you're going to institute active management. And therefore, if a woman wanted active management, then that would happen before birth. So the aim was to provide obstetric and neonatal care directed towards providing life-saving perinatal interventions that would optimise that baby's survival chances and of surviving without major neurosensory disability. And if the parents chose palliative or comfort care, then that would mean that obstetric and neonatal management was not directed towards providing life-saving interventions for the baby, and that the agreed plan would be to provide comfort care for the baby after birth. And of course, we then had to think about what are we going to do in the situation where parents change their mind? And that was another, ethically, we can have a lot of talks about that at the end of the session, but another very challenging area. And so it was really important for us, first of all, to sort of understand, well, how many babies were we talking about in Victoria? Where were these babies being born? How often, or like what proportion of babies were currently being offered active versus palliative care? How many survived? What were their long-term outcomes? Were there any existing guidelines for clinicians that we could actually draw from? And very fortuitously at the time, the Banff guidelines had just gone out for public feedback. And so we had the opportunity to look at the Banff guidelines and comment on those. And then the final Banff guidelines were published when we were midway through developing the Victorian one. So that was extremely helpful for us to sort of look at were we aligning. But what was interesting was we saw the same challenges for those developing the Banff guidelines as we experienced here. And of course, we also looked for, what resources were there for families. So just to quickly tell you a little bit about what we were dealing with in Victoria. Like every year in Victoria, and this is my most recent data, this has just recently been published, so you can see this paper, but around 100 babies are live born at 22 to 24 weeks in Victoria every year. So it's not an insubstantial number of babies for whom we're having to make really, really important decisions about their care. Quite differently to what we're seeing perhaps in the UK and Sweden and other countries, is there is still very much a reluctance at this point to offer active management to babies born at 22 weeks. So we can see in the babies who were born between 2009 and 17, only 5% of live births at 22 weeks in Victoria were offered intensive care. And what was interesting about those babies, it was 10 babies, was that 5 of them were actually born in paramedic practice, meaning that they were born either at home accidentally or were born in an ambulance on the way to a hospital. And in fact, of all the babies who were actively resuscitated, only 2 were born in a tertiary centre. So that was quite interesting. At 23 weeks, we saw the differences started. So 55% in Victoria still offered comfort care, so very different to the UK, and 45% actively managed. And by 24 weeks, we saw almost a complete reversal of what we were seeing at 22 weeks, and that was that just 10% were offered palliative care and 90% were actively managed. And I should point out these were babies who did not have major congenital anomalies that would have been life-limiting anomalies. So these were babies, live births free of lethal anomalies. But what was interesting about them was when we looked at where they were born, we saw that in fact nearly half of the 22-weekers were being born in tertiary centres. We thought it was interesting that in fact caesarean sections were being performed for these, not for many, but for a few very immature babies. But when we looked deeper into the data, what we saw was in fact that of those who were delivered by caesarean section, it was usually for maternal indications, not for fetal indications. So the caesarean section was done to save the mother's life. So for example, where there was fulminating hypertension, preeclampsia or eclampsia. And we saw a really low antenatal corticosteroid rates for the 22-week babies, but that went up considerably at 23, and then it was nearly 80% by 24. So that was the data for, that was all live births. But when we actually looked at actively managed babies, we saw quite a different story. So only 20% of actively managed babies were actually born in tertiary centres, fairly equal proportions of 23 and 24 weekers, but that also meant there were 15% of very immature babies being outborn and actively managed, so born in non-tertiary hospitals and then being transported by the Piper retrieval team to a tertiary centre after birth. Again, we saw that increase in caesarean section rate from between 22 to 24 weeks and a much higher uptake of antenatal corticosteroids. Now, I'll tell you what happened to these babies shortly, but the other interesting issue that we looked at was where these babies were being born and how likely they were to be actively managed. So just to tell you again a little bit to orientate you with Victoria, so you remember about the size of the whole UK. Now we have 67 hospitals. We currently have 4 now, what you would call level 3 or tertiary centres. We now call them level 6 A and B. And all our tertiary centres are located in the Melbourne metropolitan area. So imagine if every baby born in the UK had to come to Manchester to receive intensive care. That is the best analogy I can give you to sort of relate. So all our other hospitals are located anywhere up to our furthest hospitals, about 550 kilometres from the nearest tertiary centre down here in Melbourne. So we have a number of very small level 1 hospitals that don't have paediatricians on site, certainly don't have an infant ventilator, have a very basic nursery, limited diagnostic services for, for doing blood gases. So really challenging for these smaller hospitals if they have extremely preterm babies born there. So what did we see with the outborn babies? Well, we saw, not surprisingly, that they were less likely to be offered active management at birth. There were some pretty good reasons for that. But they're also less likely to receive life-saving perinatal interventions before birth. So we saw that 43% of our outborns versus 91% of our actively managed inborns, for example, received corticosteroids. We saw that outborn babies were less likely to be successfully resuscitated. So even when resuscitation attempts were made, that the babies who were outborn, 21% of them died before they could be transferred to a tertiary centre versus just 3% of inborn babies. So that was important because what it says, if the parents want active management, then really trying to get that baby born in a tertiary centre is incredibly important. Not surprisingly, we saw, of course, that if they were actively managed, they were still less likely to survive to 1 year of age. And so it was really armed with all this knowledge that we then had to sit down and sorry, I should just say, though, there were some pretty good reasons for those differences. As I pointed out, there were women who delivered at home or en route to hospital, about 6%. There were women who presented in precipitate labour to these small hospitals and there was just no time for in utero transfer. There were births that were undertaken for maternal indication, so caesarean sections to save the mother's life. As we saw, a higher proportion of outborns died in the delivery room. But we also saw that in utero transfer was not always accepted by a tertiary centre until the woman was 24 weeks. So sometimes a hospital would ring and say, we would like to transfer this woman, she's 23 weeks and whatever days. The family have been counselled, they want active care, but the tertiary centres would say, no, call, ring us back when she's 24 weeks. So that was a problem. And the other thing we saw was that perhaps decision-making based to not opt to active management may have been on perceived risks of death or disability, survival with disability. And we actually questioned whether even clinicians counselling parents actually had accurate perceptions of outcome of these babies. And this is what, sorry, I should say, this was some work I did as part of my PhD work where we actually looked at, do clinicians who are counselling these parents about active or palliative care, about survival chances, about potential outcomes, how accurate are their perceptions? And as we all know, it is incredibly hard to keep up with outcome data. And the other challenge is that by the time it's published or you've done the follow-up of the babies and it's published, it's 10 years down the track. And can you compare the outcomes of babies born in England in the Epicure study with babies who were born in France in Epipage, with babies who were born in Australia? So it's very difficult for clinicians to keep up to date. But what we showed, and this was a little study we did where I asked clinicians so this was our midwives and nurses, obstetricians, tertiary centre staff, and our transport team, what do you think the chances are of a baby surviving if they're outborn at 24 weeks? And at the time, the true survival rate was 37%. Now, as you can see from the box and whisker plots, and just to orientate you in all of these, the solid line is the median. The outer ends of the box plots are the 75th and 25th centile, and the whiskers are the 95th and the 5th centile. So across every profession, even obstetrics and tertiary centre staff, we saw that people underestimated survival. We then said to them, what do you think are the risks of major disability in a surviving infant? And we defined that as major problems with walking, talking, thinking, seeing, hearing. And what we saw was, again, across the board, that people thought that if you were outborn and you were 24 weeks and you survived, that your chance of major disability would be somewhere around 70%, when in fact the true rate was down here. And we asked the exact same question of staff, well, what about babies who were inborn? And we saw people were closer in their estimates of what the true survival rate was, but generally underestimated survival. But once again, this huge overestimation of disability. And this really made us question then, what are we telling the parents of extremely preterm babies? And so this all had to be taken account when we started developing this guidance for births. And it was a huge project. And I look back now and think, how on earth did we do it? So the first thing we had to do was we had to define the zone of parental. And I'm sure for all of you doing an ethics module, you will be very familiar with this concept, but of course the zone of parental discretion refers to an ethically protected space where parents have the discretion to choose between active versus palliative management for their baby at gestational ages where outcomes of medical treatment are uncertain. And throughout all phases of counselling and decision-making, of course, the emphasis is always on shared decision-making with the treating team and the parents. But in the zone of parental discretion, it's ethically legitimate for parents to make the final decision, even if that is not what the treating team would necessarily recommend. And we really looked and drew very heavily in, and I thank Dominic Wilkinson from the John Radcliffe for his assistance on this as well, because Dom was fantastic in helping us. Decisions about whether active care is within the zone of parental discretion must incorporate an assessment of the likelihood of both mortality and morbidity for the baby that considers both gestational age, but also other factors that we know affect fetal and maternal health, and I'll talk about those. And when it's determined that a combined outcome of greater than 90% of dying or of surviving with severe disability constitutes harm. I'm just going to pop you on mute there. No, actually, I can't do it. Alok, you can put that person on mute. So when it's determined that a combined outcome of greater than 90% chance of dying or surviving with severe disability constitutes harm, then active management is not considered to be in the best interests of the baby. And so we came up with this diagram, the zone of parental discretion. And it's a continuum, and therefore it's not, the colours are not solid. There's no it's a continuum of care. But we decided that below 22 weeks and 0 days, that life-saving interventions would not be supported, even if the parents really wanted it. That below 22 weeks, there really was, no chance for the baby. That 24 plus naught or above, that active management would be provided unless there were significant adverse risk factors to not provide active care. And therefore, the zone of parental discretion, we decided, sat somewhere between 22 plus naught and 23 plus 6 weeks. But within the zone of parental discretion, there is a huge emphasis on both shared decision-making, respecting family values and beliefs. However, the management plan will also take into account realistic assessment of individual risk factors that will determine the strength of the directions in one direction or the other. So if you were outborn, that would push the zone of parental discretion this way. If you were severely growth restricted, if you were male, if you were a multiple, if you had an anomaly, whether or not your mother had been given antenatal corticosteroids. So for example, we decided that if a baby was outborn below 23 weeks, then that in fact would not be within the zone of parental discretion. So the idea of the zone of parental discretion is that it is a continuum that can move in other direction. But when we first designed this, the upper limit of the zone of parental discretion we actually had at 25 plus 0 weeks. And when we put our first guideline out for review and sector feedback and public feedback, we got a lot of very strong pushback, particularly from the tertiary neonatologists, that they would not feel comfortable not resuscitating a well-grown 24-weeker in the absence of other risk factors. And so when we came up with the final version of the zone of parental discretion, we did lower the limit to 24 weeks. Now, yes, so I've just said all that. Some of the parent counselling considerations when you're going to talk to these parents. Now, obviously, it's very hard at the time, but you're trying to help the parent or encourage the family to consider both the immediate and long-term outcomes. And I'm sure you've all seen this, but that initial reaction often that the parents just want everything done. As our obstetricians say, put the stitch in, give antenatal corticosteroids, do everything. But this might not necessarily reflect their final decision once they've had time for counselling and to really consider all the options. And parent counselling, of course, also needs to consider obstetric and neonatal factors that may really change, again, the direction of the zone of parental discretion. So, for example, in situations where the mother's had preterm prolonged rupture of membranes, or has oligohydramnios at critical time points when the fetal lungs are growing, whether she has got evidence of chorioamnionitis and sepsis. In multiple pregnancies, is there evidence of twin-to-twin transfusion syndrome or fetal growth restriction? Again, as I talked about caesarean section, what implications does that have for future pregnancies, and whether there's any congenital anomalies? And although it sounds all very easy for us to say, well, this is the zone of parental discretion, we know that for parents making decisions within the zone, that this is really, really hard. And I will send you this paper, but this is a beautiful paper written by Jenny O'Neill, and she is actually a nurse at the Royal Children's Hospital here in Melbourne. And Jenny works in developmental medicine, interestingly. But several years ago, Jenny, in 2007, Jenny's daughter was born extremely preterm at 23 weeks in a non-tertiary hospital. And at that time, Jenny's obstetrician was away. And so she had an obstetrician that she'd not met who came in to talk to her about the decisions that they had to make about whether or not to offer intensive care for Lily. It's a wonderful article. It really gives you a beautiful viewpoint of the parents. But some of the statements that really stood out to me in this, and Jenny is a friend of mine, but she said, in this paper, the grey zone felt like an impossible place to be. A matter of days earlier or a week later, and the burden of decision-making would have been quite different. She said, my mother was with us at the time, and as she left the room, she said, Jenny, whatever decision you make, it will be the right one. And in this moment, I couldn't understand this statement. How could either decision that we were faced with be the right one when both options seem so wrong? So I think I don't ever envy anyone who has to go and counsel parents about these choices, and certainly being parents of these babies, must be extremely hard to make these very, very difficult decisions. So just briefly to show you some of the considerations we thought about for care of the woman in the guideline, both in tertiary and non-tertiary hospitals. We decided that if active management was going to be provided, then that would mean in utero transfer to a tertiary centre. And that would, if the parents were adamant that they wanted resuscitation from 22 weeks and there was no other adverse risk factors, that we would transfer in utero. That antenatal corticosteroids, if the mother was at risk of birthing at 22 weeks, would be offered from 21 plus 5. But we wouldn't routinely give antenatal corticosteroids to all women at 21 plus 5, only if it was evident that the woman might deliver at 22 and that they strongly wanted resuscitation. That we would administer fetal magnesium sulfate for fetal neuroprotection. The mode of birth, still very, very contentious, but it would be discussed with the mother about the risk for her current pregnancy, for her future pregnancies. But what we saw with most of these babies was the vast majority of them actually spontaneously labour and actually deliver vaginally. So mode of birth is not always such a big issue to discuss. Fetal monitoring in labour is recommended, but of course extremely hard to try and get a fetal heart monitoring when a woman is only 22 or 23 weeks pregnant can be very challenging. And if the parents had opted for palliative care, then we would still consider in utero transfer to a tertiary centre, even if that was just for counselling. So if the parents were unsure or didn't know, but were leaning towards palliative care, but weren't positive, 100% convinced that's what they wanted, that they should still be offered, if they wanted it, to be transferred to a tertiary centre so they could receive further counselling from high-risk obstetricians and neonatologists. And that didn't mean that they would have to have active care. It would just give them that opportunity to have more time and to have counselling with people who are obviously expert in this. But that we wouldn't give antenatal steroids, we wouldn't give magnesium sulfate, and there would be no caesarean sections for fetal indications. And so the flowcharts we came up with look like this, and I will send you all these, so there's no need for you to try and have a look at this, but we had our flowchart for non-tertiary units and tertiary units. And one of the key principles for non-tertiary was that when the woman presented, that within 30 minutes of her presenting at that hospital, that she would be assessed clinically by a senior staff member of the obstetric or maternity team, that if she was at high risk of birthing, that there would be counselling, determination whether transfer to a tertiary centre was safe, and that's what the parents wanted, and then initiate the active care pathway. So that's what the maternal guideline looks like. And as I said, if after counselling the parents are uncertain or clearly want active management, then we felt that in utero transfer should be offered from 22 weeks. And that doesn't necessarily imply that active management will be the ultimate approach, but that was important. And the other component we wrote into the guideline was that a lack of NICU beds or a bed block in maternal beds in tertiary centres, which we see many days here in Victoria, should not stop in utero transfer of a very immature baby. And that the transfer of a woman who was greater than 25 weeks should not take precedence of the transfer of a woman who is less than 25 weeks, so that irrespective of the gestational age, that both women would be given exactly the same, in utero transfer would be undertaken with the same level of enthusiasm. And that once there was consensus for an urgent transfer, that no beds could not impede the delivery of best care. And if barriers were met, then the bed finding process would be escalated to a higher level to find that woman a bed. In terms of the baby, again, we had to look at both tertiary and non-tertiary care. So for active management, we said that ideally the baby would be inborn in a tertiary centre, and that if that was not possible, then to consult with the Piper team as soon as possible if outborn birth was unavoidable. Obviously, for active management, that the baby would be resuscitated at birth. and ideally that a consultant-led team would resuscitate that baby. Now, in many hospitals in Victoria, there won't be a paediatric consultant, but so this was ideal practice, best practice, and that you would then admit that baby to an intensive care unit. And if you're offering palliative care, then they could be inborn or outborn, that we would discuss with the parents where they would like their baby cared for. Did they want to stay at the birth hospital where they know the staff, they've got their family, they've got their supports, or do they want to be moved down to Melbourne, which may be 500 kilometres away from their home and their other children? That the baby should stay with the parents as long as the parents desired, and that hospitals should be able to provide a cuddle cot, which is the cooling cots. We talked about how supporting parents to create memories and helping hospitals that may not necessarily have a lot of experience with palliating a live-born baby to help them, and that it was really important that there was opportunities for these parents for bereavement care and for follow-up. And so again, the active management pathway for the baby really is again around, resuscitation. And that brought us to the parent information sheets. And one of the first things we did was we went to our consumer advisory group at the Murdoch Children's, where I do my research. And this is a group of parents and ex-premature babies. And the parents are parents of current babies in NICU, babies who were in NICU 20 years ago, parents whose babies died, and parents whose babies have survived. And of the survivors, some are parents of children who are quite disabled, and others are parents of babies who've done extremely well. And so we went to the consumer advisory group for their help into developing the parent information sheets, because we felt they had the lived experience. They'd been through it, and they knew more than we could ever imagine what it was like to have a baby born this early. And in the first focus group I ran with them, some of the reflections of the group, and I remember this mum saying this, was she said, we weren't given any written information at the time, and I really wish that we had, because we were just told and we had to make a decision. And what was interesting was when we did the parent information sheets, we didn't think parents would want really specific information on numbers. We didn't think they'd want statistics. But they told us they did want numbers, but they wanted to know how many babies would be deaf, how many babies would be blind, how many babies would have cerebral palsy. And so we ended up putting that information into the parent sheets. They told us very clearly that they wanted a description and they wanted detail of what comfort care would actually entail, what would happen if they chose comfort care. And they wanted the details around what that would mean. But they also wanted details about what it would mean to have a baby in intensive care. So what sort of procedures would the babies routinely go through? How long would a baby stay in intensive care if they were born at 22 weeks? And we talked to them about what about having photos and images, and they decided that these would be too emotive before birth. And that each tertiary unit has its own information book that has pictures of their ventilators and their equipment and information about that particular unit. And so we decided, or the parents decided, that we wouldn't put images of babies into the parent sheets. And so that was the decision that we made to not do that. And so for each gestational age, we have parent information sheets that use infographics as well as information. And so we talked about, in terms of survival in ideal circumstances, and that would be born in a level 6, a tertiary centre, and mother had received antenatal corticosteroids, and that this was the chances of the baby surviving. And then we have in less than ideal circumstances, which would be not born in a tertiary perinatal centre and no antenatal corticosteroids, to show them how survival chances change. In terms of major disability, we drew the data from the Victorian Infant Collaborative Study cohorts over several years, over 30 years, nearly here in Victoria. And we also drew on data from the Australian and New Zealand Neonatal Network. So for example, for the 23-week babies, we had data for, I think it was just under 100 survivors born recently to look at the risks of disability. And the final tool that we developed, just mindful of the time there, was a tool to help clinicians to estimate outcomes for these babies. And this was not done as part of the Safer Care guideline per se, but this was some work that I was doing as my postdoctoral work as well, but it fits in quite nicely with the guideline. And so we developed a preterm birth outcome predictor. And this is a little tool that's designed for babies born in Victoria, and it's designed for clinicians to use prior to the baby's birth. And it's not, it's an adjunct for counselling. So when a woman presents, the clinician, similar to the NICHD outcome predictor, but the difference is this: you can use this one before birth. So you put in the gestational age of the baby, whether they're male or female, and if you don't know, then female will give you the better survivor data, and putting in male will give you the poorer survival outcomes. Whether or not the mother has received antenatal corticosteroids, and whether this baby will be inborn or outborn. And basically it then calculates the risks of dying, of surviving free of major disability, and surviving with major disability. And the idea is that then a clinician can say to the mother, but look, if we give you antenatal corticosteroids and you're inborn, this is how your baby's predicted outcome can change. So that's a tool we're just literally finishing and just launching. Haven't validated against other cohorts yet, but I would hope to do that in time. So I can tell you more about that. So just in summary, I think we've seen around the world that there is certainly increasing willingness to provide intensive care for these very immature babies in many high-income countries, but certainly not all. Still, we see at the moment that active management is actually still quite rare in Victoria. So only 10 babies actively managed over the past decade. So very small numbers. But by 24 weeks here in Victoria, nearly 90% are actively managed. And of those, 2/3 will survive to 1 year of age. And their disability data is actually quite promising as well. And so if parents want active care here in Victoria, then our guidance, statewide guidance now says that birth conditions should be optimised. So transfer in utero, give antenatal corticosteroids, give magnesium sulfate, have a consultant-led team attend the birth to resuscitate the baby, ensure there's multidisciplinary counselling for the parents around survival chances and long-term outcome, and that at all times the emphasis should be on shared decision-making with the parents. So I'm going to stop there, just acknowledging all my data sources, and open up the floor to any question. Oh, Alex's going to manage the questions for me. Depending on how we go for time and questions, I have got some information on the long-term outcomes of these babies, but I thought we might, given that this is focusing on the guideline and particularly along the ethical side of it, I thought I might see what questions come up from that first, and then if we have time, we can look at the long-term outcomes.
So I'd like to take this opportunity to thank Rose for what was an absolutely amazing presentation. Thank you so much. I think we have a deluge of questions, not unexpectedly. And what I'm going to do is, I think we'd really be, and we have enough time to actually go through the neurodevelopmental outcomes, which we can probably structure towards the end of the presentation. But I'm going to start by asking questions from the participants from YouTube first. And I've got a question from one of my nurse colleagues who works in a level 2 center. So her question is, does the condition of the baby at birth, especially between 22 and 24 weeks, influence your decisions to stop resuscitation considering your guidance? And
right, that's a fantastic question. Thank you for that. So many of you may know Dr. Brett Manley. He's a researcher here in Melbourne. Brett wrote a paper published in Pediatrics a few years ago, which was looking at the outcome of babies based on how they looked at birth. And what Brett showed was there was no correlation to how the baby looked at birth and their survival chances. And so we said, we have actually written that in the guidance, that the condition of the baby at birth should not be used to determine whether or not resuscitation should be offered. So in fact, we made that very clear, that no condition at birth. So it wouldn't be, oh, let's just wait and see what this baby looks like when it's born, because we've shown, or Brett's work's shown, there is no correlation between how a baby looks and how they're actually likely to do. And you know yourself, if a mum's had a GA section, that baby's not going to come out and breathe. They can be, you know, very poor condition at birth, but it doesn't actually mean they're going to do poorly. So that's a great question, and we certainly have written that into the guideline.
So just a follow-up question in regards to that is, obviously we've kind of minimum interventions, you know, the response of the baby to your resuscitative efforts. Now, the BAPN guidance kind of talks about definitely trying to inflate the chest, intubate, give these babies surfactant. Have you defined a minimum level of intervention,
Yes,
you know, especially at 22 weeks?
Yes. So exactly, so similar. So A, B, C, D, you know, of airway, breathing, circulation, surfactant, intubation. I mean, it depends on the condition of the baby, but yes, that's all outlined in the resuscitation flow diagram for them. Yeah. And again, we did it for tertiary and non-tertiary, because in many non-tertiary units, they would not necessarily have someone with the skill to intubate a 400-gram baby. And so for them, we couldn't say, oh, let's, you know, we couldn't say to them, do blood gases and do things that we know aren't feasible in some of those units. So that was very deliberately why we wrote 2 pathways. You know, to have the best resuscitation you could, but acknowledging that many non-tertiary hospitals just don't have the same, they don't have even the numbers of people to come and help at a resus like we do in a tertiary centre, where you've got a cast of many people and many experienced hands, and, you know, all the right equipment at hand.
So we have another question from a colleague of mine. So this is a tertiary consultant who works in India, who's taking up the module. So in terms of CPR for babies 22 to 24 weeks, I mean, inflating the chest, how far would you go towards giving compressions and drugs in your setup?
That was an interesting question, Alec, and I'll actually just go back a slide, if you don't mind. I'll actually show you the slide. So what surprised me was when I actually looked at, oh, sorry, no, that's not the one I want. When I actually went back and looked at, yes, this one, sorry. When I actually went and looked at the data for all our babies, I actually thought that perhaps resuscitation might have meant, oh, they gave the baby a bit of positive pressure and then didn't take it any further. But what we saw, in fact, was that these babies, the resuscitation, many of these babies had 7 or 8 different types of resuscitation interventions. And so they were intubated, they got mask ventilation, they got some CPAP, they got intubated, they certainly got some chest compressions. There were babies who got adrenaline. And when I looked at the proportion of babies, what were the in terms of survival to 1 year, more than 50% of the babies who received chest compressions and adrenaline were alive at 1 year. And so we actually wrote in the guideline that, given what we've seen, that in fact chest compressions and adrenaline may not always be futile in these very immature babies, as many people would say. So we said for that, the evidence is limited. However, that we wouldn't say don't go, you know, don't, you know, that don't not give chest compressions. What am I trying to say? So it was interesting. Yeah. So I think I was surprised by, I guess, not the aggressiveness, but how, you know, people were making good attempts. It wasn't half-hearted attempts to resuscitate these babies. If they were going to offer them active care, then they really did. Now, obviously, there were situations where in the delivery room it became obvious the baby was not going to survive. And there were certainly babies, as we saw, who died in the delivery room despite resuscitation attempts. But in the tertiary centres, that was only 3% of the live births who were resuscitated. So in a tertiary centre, if you were actively managed and resuscitated, then 90% of those babies were alive to be admitted to NICU. And that was a very different story to what we saw in the outborn babies. Yeah.
So just to follow up to the first question, so just considering the fact that when a baby's born, there's a huge amount of subjectivity as to signs of life and how we interpret them. We standardize that with monitoring. Should we be trying to define signs of life at 22 and 23 weeks so that we can be more consistent with how we're approaching every baby?
Gosh. So here in Australia, we do actually have definitions of, which are written by the Perinatal Society of Australia and New Zealand. And we actually have a definition of what a live birth is versus a fetal death or a stillbirth. And for live birth, our definition is that, and I quote, after separation from its mother, it's a terrible statement, that the fetus shows any signs of life, including pulsation of the cord, movement of involuntary muscles, breathing. There's a fourth one. Oh, can't think of the fourth component, but it can be not necessarily that the baby comes out and is crying. It can simply be that the cord's still pulsating, or that there's movement of the muscles, and that is in terms of our coding of live births and stillbirths, that baby would be coded as a live birth, even if we never heard it cry and nobody ever heard a heartbeat. Now, that doesn't mean we'd resuscitate that baby. And again, I think what's really important with the guidelines is that each baby is individual, and each mother is individual, and each circumstance is individual, and you can't have a one-size-fits-all. You can't say, do this at 22 weeks, or you've got to, it's always individualized. And I think that's one of the really important points about it, is that it's not saying to people, you've got to do this, or you must do this. It's simply a guideline to try and provide some consistency across the state. But of course, every individual baby's management will always be individualised. And that will depend on the team resuscitating them as well, won't it, Alec? Some people will keep going a bit longer than others, so it's a tricky one to answer.
So I've got a question from one of our participants who's a consultant at one of our level 2 centers, and she has a really interesting question on the challenge of counseling parents who would have expectations for resuscitation in level 2 centers in Australia where they can't be transferred out. Clearly there would be expectations from some parents that their babies are managed. And how do you deal with that in terms of counseling? I mean, in terms of, especially if there's disagreement and the challenges around that.
So first of all, we have a single centralised retrieval service for the whole of Victoria, and that's Piper. It used to be called NET, so it used to be the Newborn Emergency Transport Service, but now we're perinatal and neonatal and paediatric. So a Piper consultant can help provide information for the doctor at the other end of the phone who's saying, what should I tell these parents? And what we've talked about is that we really need to expand our telemedicine so that a Piper consultant can actually be, like we're doing right now, zoomed in with the parents and the referring hospital staff to have that joint discussion. And that's something we put into the guideline to say we really need to move towards more telehealth. And if COVID's proven anything, it's that we can certainly do it, and that would be one way to overcome exactly that issue that you're describing, that real challenge of clinicians who are faced with having to counsel parents, and they may not deal with this very often, as in the clinicians might in their hospitals. We looked at how many babies, a year. It's not many.
So, follow-up question to that from Tori Payne. Do you feel that the Victorian level of care classifications for neonatal units might then impact the outcomes for outborn babies? Clearly considering the geography and the distances, and how would, in that question, are we kind of then talking about the self-fulfilling prophecy? And
sorry, that's my whole postdoctoral work, my whole PhD work. I've spent the past 10 years looking at outcomes of babies born in level 1 and level 2 hospitals. Yes, so it is my life passion. I can send you many, many papers on that. Does it have an effect? I guess the thing is, ideally, so the idea of this guideline is that if a woman presents to a level 1 or level 2 and the family clearly want active care, then every effort should be made to get that woman to a tertiary centre. That's the bottom line, because we know the baby's outcomes will be better, both in terms of survival and in terms of long-term outcome, if that birth occurs in a tertiary centre. So every effort will be made. And because we have a single centralised transport team, we coordinate all the in utero transfers and the bed finding and the battles with the bed finding and the mode of transport to get that woman down to Melbourne. And if it depends on how immature the baby is, but if it's inevitable that the birth, if she cannot be moved in utero, then we will try and get a Piper team to be at the birth. So we will then do it backwards. We'll mobilise. When I first started in Piper, we used to say, "Oh, call us back when the baby's born and the baby's alive." Whereas now it's like, tell us as early as you can so we can get to you. And if you can hold, or it's impossible usually, but if they're planning on doing a Caesar, for example, can you hold off till we get there? And so we will be at the birth so the Piper team resuscitate the baby. Now, for an outborn 22-weeker, that would not be the case. But for births generally under 28 weeks, we try to be at the birth if they can't get the mother to us. So that's been another initiative with the retrieval service. So then you've got a specialised team resuscitating the baby. Not always possible.
Completely understandable. And I think, if we look at the diversity, the distances, the geography, and I think that would pretty much answer one of the other questions that's been put forward. So we discussed all the guidelines last week for, kind of management at limits of viability from 27 different countries. And it was a really interesting kind of an overview of how there's been a huge amount of progress. And obviously, if you look at the BAPM and the new guidelines from Victoria, a risk-based approach is something that's coming into vogue in a big way. The question that I had in particular is, Australia is so diverse, it's massive geographically. Is that the reason why other states have not yet adopted such an approach, or are they in the process of doing it? And
Yep. So yes, although we are one country, we are, as we've seen in COVID, we are very much separate states. Borders locked down. There has always been a really different approach in different areas of Australia, which is quite interesting. So WA, Western Australia, they have a single tertiary centre, which is in Perth. So that huge geographical space, and all the mothers come to Perth to King Edward Memorial Hospital. And their outborn birth rate's actually really good. They have like less than 10% of outborn babies over in WA, despite those huge distances. Now, they've always been quite proactive with managing very extremely preterm babies, way more than any other state in Australia. New South Wales are still less. Victoria's a bit more. New South Wales is still, it's really 24 weeks. But in New South Wales have actually just put together a steering committee to develop their own guidance. They came to us and to me and said, this is silly for us to reinvent the wheel when you've done all this work. Can you be on our steering committee? So at the moment, I'm helping New South Wales to develop theirs. And because I'm obviously from New South Wales and trained there, I do have a very good insight into their hospitals. Queensland also developed their own guideline. And again, they're a very big geographical state. All their tertiary centres are in Townsville and Brisbane. So they already had their own guidance, but they had not developed it down as low as for 22. They'd only started it at 23. And we felt in Victoria that we couldn't close our eyes and pretend that we couldn't hear and see what was going on around the world. And that parents aren't stupid. They read social media. They know what's happening. And so we couldn't bury our heads in the sand and say, well, we'll just pretend the 22 weekers will go away. So each state remains same, but different. And each state does have its own approach. And it's always been very interesting that, we're one country and yet we have very different management.
I would echo that we're actually smaller. And if you look at management in the UK, there's a really nice paper that's been published by Professor Marlowe, which actually looks at, the differences in management just from the north of the UK to the south in terms of active intervention.
Perinatal, intensity of perinatal care, Neil's paper, yeah.
So, I completely echo that sentiment. So there's a question from one of our consultants who, again, so certain aspects obviously very difficult to quantify. And similarly, like if you had multiples at 23 weeks in a level 2 center, would you approach that similar to babies born at 22 weeks? And that's really tricky.
It does push the zone of parental discretion slightly that way. And so, if you had outborn twins, oh, Prince Philip's just died.
Oh dear. Okay.
Oh, sorry, it's just come through my breaking. Sorry, I just looked down and saw that. Oh dear. Oh, sorry, Alok.
That's all right.
Shock. Shouldn't have said that out loud. I just looked down. Suddenly it's just flashed up in front of me. So what am I saying? Okay, outborn, 23 weeks, male, no antenatal corticosteroids. We know those babies' outcome is going to be so much poorer than inborn, female, well-grown, steroid-loaded girls. And so that would push the zone of parental discretion a little bit downward, because you would say, well, these babies' survival chances are just not as good. But that would be part of the counselling of the parents as well, to explain to them why, all babies are not the same. And it's a bit like with paramedic practice. When I do a lot of training with paramedics, I help them write guidelines for babies. And I say to them, yeah, sure, in a hospital we resuscitate 24-week babies, and they do well. But when they're born in the toilet at home at 24 weeks, that's a completely different story. So you can't treat them the same. You can't expect the same outcomes, and you can't, expect that what's going to happen in a hospital at 24 weeks is remotely possible when a baby's born in the back of an ambulance or en route to hospital. So again, I think it comes down to individualising care for each pregnancy, each baby. And so while we were trying to create broad guidance principles, of course we kept coming back to the fact that it's just a guideline, and there will always be individual circumstances. And again, hospitals are encouraged to ring Piper, to talk to the obstetric and or neonatal, or both at the same time, conference call with both consultants about what the appropriate options are, what to tell the parents, and what to offer the parents. And that's always an individual decision, always.
So just a comment from one of our, and a follow-up question from one of our nurses. So, I mean, I think what she said is absolutely fantastic, to have a policy of accepting babies, irrespective of your unit size, and trying to facilitate those transfers, because it can be a huge anxiety for level 2 and level 1 centers. So,
very anxiety provoking. Yeah. And the other thing we saw, and this was a couple of years ago, was that sometimes a level 1 or a level 2 would ring through saying, I want to transfer this woman, and they'd be told, oh, we don't resuscitate babies at 23 weeks. And yet they would then have back transfers of babies coming back to their unit who'd been born at a tertiary centre at 23 weeks and were now 100 and whatever days old, coming back to. So they knew that there was this mixed messaging, people saying to them, we don't resuscitate babies at 23 weeks. And yet they knew that there were 23-week babies in the tertiary centres. So the messaging was inconsistent, and that was something that was really important to address in the guideline, so that all consultants at tertiary level, Piper, across the board, would not say, we don't do this, or we won't move her until X gestation. And that was a really key component of this guideline. And to do that, we had to get consensus from all the tertiary units that they would agree that there could not be bed block, there couldn't be priority for more mature babies, and that they would all agree that if we put this in the guideline, that they would that they were willing to accept it.
So another really good question from one of our grid trainees. So she's spoken about the balance of cesarean section as active intervention in maternal interests versus, a baby born at 22 weeks. What do we think about offering cesarean section for survival of the baby and making its chances better?
So we looked at that really carefully, and we looked at the evidence from around the world, and there wasn't compelling evidence to actually show a survival advantage for cesarean section over vaginal birth at 22 weeks. And so in the guideline we wrote that with a lack of clear evidence to support or refute that it would be an individual decision, but you would have to discuss with the woman the implications for her future pregnancies, given that you would be doing a classical cesarean section at 22 weeks. So for fetal indications, that it would have to be really clear to the mother what the risks were, both for this pregnancy as well. But that's still major operation.
What I was going to do is I was going to let Rose share with us the neurodevelopmental outcomes. That would be fantastic. Yep.
Sure. Yeah. Let me just get those up. So as I talked about when I did that work about what people thought happened, and we showed, people really overestimated disability and underestimated survival. What we then had to obviously show people was what, both in the parent information sheets, but also, sorry, I'm just scrolling across on my second screen to grab this up, was to show, well, what happened to these babies? Because what we didn't want to see was more babies being actively managed at 22 or 23 weeks, but with the result that we had more severely disabled survivors. So that was important. So it was important, therefore, that we looked at, well, what were the disability rates in our survivors? And we wanted to look at both what was happening here in Victoria and as well as looking internationally, because the numbers obviously in Victoria were small. So I will show you, let me just grab that up. Sorry, I'll just stop sharing for a minute. Just chat Alok for a sec while I just move that screen around. I'll just get that one. Okay. Just got my double screens running here at home, so I'll just, got that up now. So here in Victoria, we have a group called the Victorian Infant Collaborative Study, and this was set up by Lex Doyle took it over some time ago. Professor Jeannie Chong's now the convener of VICS, but was set up back in the 1970s, really by Bill Kitchen. And Bill was a neonatologist who realised the importance of not only providing intensive care for babies, but actually following them up into childhood to look at their outcomes. And so the VICS study is quite unique in that it has data from, we're now seeing 30-year-olds being assessed, followed up at 30 years of age. So similar to Epicure. They follow up children born extremely preterm or extremely low birth weight, so under 28 weeks, under a kilo. And this was the data. So these were children who were assessed at 8 years of age, so it's school age, and the children had also been seen at 2 years, but what we saw was looking at their outcomes at 2 years did not actually predict what they'd be like at 8. So as you can see, across the VICS cohorts, and this was a few of the VICS cohorts, only 7 babies were offered intensive care over those VICS cohorts, with just 2 survivors. One of the survivors was not assessed, so therefore we don't know whether in fact that child was severely disabled and that's why they didn't come for follow-up, or whether the baby was doing well, or whether they'd moved interstate. And one had major disability. 23 weekers, no major disability though in 67% of survivors, and in the 24-week babies in Victoria, no major disability in 75% of our 24-week babies. And so Jeannie's just published this recently in the Lancet Child and Adolescent Health, and we're just about to publish the data for the 2-year outcomes for our VICS cohort who were born in 2016, 2017. So I won't give away that secret yet. It's just about to be published. But of course, we were interested in looking at, well, what was happening around the world and how do we compare in Victoria to some of the other countries. So this was a very a recent meta-analysis published in Pediatrics, and this was looking at children from high-income countries who had been offered intensive care at 22, 23 and 24 weeks. And in this study, they looked at the meta-analysis looked at survivors with severe impairment, and that was defined as children who had moderate to severe cerebral palsy, so unable to walk or walking with considerable difficulty, or with or without a walking aid, with a gross motor function classification system score of level 2 or greater, blindness, deafness, or an IQZ score less than 2 standard deviations relative to term-born controls. And always really important in any follow-up study that you have your term-born controls, because of course there is a proportion of term-born children who also have impairment. So all the VIX cohorts always have term-born controls in all of them. So what the meta-analysis showed was at 22 weeks, 36% of the 22-week babies were surviving with severe impairment, 22% of 23-weekers, and 19% of 24-weekers. If you flip that data around and actually look at these survivors who were free of impairment, I think this told a story that surprised some people, and that was that a quarter of the babies born at 22 weeks survived free of impairment. 35% of 23-weekers and 40% of 24. And so when we first did the parent information infographics, what we did was we put this together in a little infographic for the parents to help them sort of, to see if this was helpful for them in understanding outcomes. And so this is just from that meta-analysis. So this was the chances of disability in babies who were born at 22 weeks and survived. And for the parents, we described it as problems with intelligence, language, motor, vision, hearing, cerebral palsy. And as you can see, 24% no disability, 36% severe, and 40% mild or moderate. And so we're interested to see, well, how does that compare with babies born around all Australia and New Zealand? And we have an organisation called the Australian and New Zealand Neonatal Network, or the ANZNN. And this is a study that reports outcomes of babies admitted to all the NICUs across Australia and New Zealand, quite a rich data set. And they also follow up these children. So this was the data from our most recent ANZNN report. So the 2017 report, but for babies who were born across Australia and New Zealand between 2012 and 2015 and offered neonatal intensive care. And then these children were seen at 2 years of corrected age. So these were data for 74 surviving children born less than 24 weeks. So in the ANZNN reports, they pull the 22 and 23 week babies together because there are so few 22-week babies in Australia. But reassuringly, what we saw was, in fact, that 45% of these babies born less than 24 weeks were surviving with no disability. And that was, I think, a story that really surprised people. Just 30% of the babies had mild disability, 18% surviving with moderate disability, and just 9% of the babies surviving with severe disability. And when we looked at the same data again for the 24-week babies surviving in Australia, and this was for a much bigger number now, so 353 surviving children born in 2012 to 2015 who were assessed at 2 years of corrected age. Again, we saw that over half the babies at 24 weeks survived with no disability, 25% with mild, 14% with moderate, and 8% with severe. So it was painting a picture for us that perhaps was more promising than many people had previously thought, and certainly that outcomes had improved really substantially. Lex Doyle's just written a paper looking at the outcomes of babies in the VIX cohort who received magnesium sulfate compared with the previous VIX babies who had not received mag sulfate, and looking at the really significant reduction in cerebral palsy rates in the magnesium sulfate babies. So again, we're seeing some of those interventions that are really making a difference in terms of fetal neuroprotection.
Thank you. That was absolutely amazing. I mean, clearly a huge number of babies under, a good cohort size showing actually mild to no disability amongst babies born at 22 and 23 weeks, albeit the 22-week population being slightly small. There's a really interesting paper that we circulated to the to our colleagues who are doing the module, which has been written by Genevieve Taylor, which actually looks at 2-year outcomes and correlates them with outcomes at 10 years. And actually, a significant proportion of the cohort of babies at 2 years who had severe neurodevelopmental outcomes have mild or no impairment
Right.
at 10 years of age.
Right.
And,
yes. Yeah, and this is why it's so important. Children's Bailey's assessments at 2 years of corrected age do not reflect what these children are going to be like at school age. And this is why the VIC studies continue to follow up these children. So we've seen them, we've got our 8-year-olds, we've got a cohort that we've seen at 18, a cohort we've seen at 25, a cohort we're seeing at 30. The 30-year-olds, we're looking at their blood pressure, their lung function, their metabolic health, their bone health, really interesting, their mental health, really interesting follow-up of these children, and seeing how much some of the disabilities that emerge into school age, like the attention deficit disorder, and that's been very fascinating within the group I work with, following the researchers who look at those outcomes.
Last question, because I know that we have to let you go, and I could keep asking questions from the participants, but one of the questions that one of my colleagues has asked is the importance of functional outcomes in counseling parents versus outcomes at 2 years, from the Baileys. Functional outcomes might be more relevant to a huge number of parents, and how do you address that?
Yeah. So obviously, and for those who joined us a little bit late, just to all disclosure, I'm a neonatal nurse, not an obstetrician, not a neonatologist. I work within long-term follow-up group, but what was interesting though, when we talked to the parents in the consumer advisory group, was that they weren't so much interested in those nuanced details.
Yep.
They wanted to know, will my child be happy? Will my child have friends? Will my child get married? Will they live an independent life? It was very interesting what was important to them, and it was more around, their kids being happy and fitting in and going to normal school, and not so much whether, specific details of what degree of functional handicap that they might have. And that came out really clearly from the parents, that in the end that was so important to them.
Thank you so much, Rose. I mean, today's session has been fantastic. I think, especially for our participants from the module, as well as from our neonatal network, we'd like to extend a big vote of thanks for you giving us time on your weekend to speak to us on, I think, a topic that's very close to my heart, at least. Yes, and that we've clearly had quite significant changes to our guidelines as well, which are gradually coming into practice. But I'd like to thank you, and obviously from our perspective, thank you from the Deanery as well as the network. Yeah.
Oh, thanks, Helen. And I'll send you a couple of papers around the various things we've talked about tonight, so you can put those on your Moodle or your LMS or whatever platform you've got. So I'll send those to you, and yeah, please, happy to share those with anyone. Yeah, and thanks again for the invite. I hope it's given everyone something, and bit of food for thought. And Alex got my email, but you know where to find me. So please don't hesitate to reach out or shoot me an email if you've got any further questions or comments. And thanks everyone so much for your time and your attention this morning. Yes, evening here in Melbourne. It's 9:30 on Friday night now. So yeah.
Thank you so much. We're extremely grateful. Thank you to all the participants.
Thank you. See ya. Bye. I'll just wait for them to all drop off there. Gradually all just leaving the room. Yeah, I wasn't, I'm just reading back in the questions now, some of that, yeah.
I didn't take the question on weight. I think the BAPM guidance talks of 350 grams.
So Lex and I actually looked at when we did the regression analysis for mortality. the obstetricians were like, what if the baby's really growth restricted? You know, can you put that in? So we put in, what we did was we worked out from the birth weights, Z scores, 3 standard deviations from the mean, and said, okay, that can be a marker for severe growth restriction if their birth weight was 3 SDs. And so we threw that into the logistic regression model, and it didn't make any difference. So what mattered was outborn, with each decreasing week of gestational age, and with each 100 grams lower birth weight you were, didn't make any difference whether you're actually male or female in terms of mortality, or if you're a multiple. What mattered was birth weight, gestation, and where you were born, and that came out loud and clear every time. Yeah.
One question from my perspective, I mean, data for magnesium sulfate, at the moment, because in the UK, we've had quite poor coverage, I would say, until we've started, I think probably in the last 18 months picking up. But I mean, in terms of neurodevelopmental outcome data, it'd be lovely to get an idea from you of how much and how big a difference it's making at the moment.
Yeah, so Lex has just published that. So I've got the paper, I've got it sitting here in front of me. That was just published in, let me have a look where Lex published that. Very new, only just published like in the last couple of weeks. I'll just find it. I'm going to send all this to you, Alok. Anyway.
That's really kind.
All these papers that might be of relevance. Here we go. So it's called Translating. It was published in the Australian and New Zealand Journal of Obstetrics and Gynae, which is a local, what am I trying to say, publication. 2021, so pretty new. And what Lex did was he looked at what proportion of live births who should have got it did, and then looked at, so overall cerebral palsy was in 6% of the survivors. Sorry, let me go back. Cerebral palsy was present in 4% of children exposed to MagSolve and in 13% of those not exposed. So an odds ratio of 0.28. I'll send you the paper.
That's really kind.
And he looked at what the uptake was, like what proportion of babies got magnesium sulfate. So sort of the pre and post, because we introduced it into clinical practice here in Australia in terms of our guidelines in 2010, I think it was. I'll have to have a look. I'm just trying to remember. Anyway, I've written it. We've got it in the paper. So we're looking at how many women actually got it.
Yep.
And not surprisingly, of course, outborns less likely. And inborns,
Thank you so much, Rosa.
My pleasure. Look, I hope it sort of hit the mark. I know there was
100%.
I mean, but I thought for the neonatal fellows, they probably wanted a bit of data as well as.
No, I think that was perfect. I think it gives us a good flavor going forwards for the next talk that we're doing is actually going to be neurodevelopmental outcomes over the last 20 years. So, it sets the scene beautifully.
Right.
One last question.
Just finished, actually. We're writing, Lex has been asked to write a series for seminars in perinatology that's due out in November this year. And I've just written the paper on for that series on changes in survival and neurodevelopmental outcome over 30 years across the world. So, so that will come out.
With your permission, are you okay for me to share the papers with just the participants?
Absolutely.
That would be really kind.
Absolutely. Yeah, that's what I'm sending them to. They're all published. They're all out there. They're all publicly available. Yeah. It's just some of them you have to, for example, for ANZDROG, you need to be a subscriber to ANZDROG or have a university. So that can be a pain for some people. So I'll just send you the whole paper. Easy. Yeah, I'm going to send them to you right now. I've got a few. So I'll send you the MagSolve, some of my outborn baby stuff, the births before arrival, the temporal changes paper, anything that I think might be of remote interest, and then you can just take or leave whichever ones you like. Pick the rest. Yeah.
Thank you so much.
So thanks again, Alok, for the invite. I'm really honoured to have been invited.
Not at all. It's an honour for us and an absolute. I think it's been absolutely fantastic. Thank you.
Thanks so much, and have a wonderful weekend. And my condolences. It's going to be a sad weekend for.
Yeah, it's going to be a sad weekend, and interesting.
Yeah. All right, I will leave you to the grief of the nation. What a sad way to end this, but and take care, and yeah, stay in touch.
So
You know
thank
where
you
to
so
go.
much. Yep, absolutely.